Hello, I'm Dr. Takeo Saio. Okay? 聞こえる? Okay. Takeo Saio, practicing physician. One of the organizers of this webinar. This webinar is co-organized with the Japan Association of Bioethics, which I belong, and the Brazilian Society of Bioethics, which is chaired by Dr. Dishu Greco. Professor Greco is highly respected in his research in infectious disease and bioethics. The title of this webinar is Pandemic and Research Ethics, Democracy, Placebo, and Post-Trial Access. Today is the second session, following the last Friday, where we discussed mainly on the ethics of placebo-controlled trial. Today's session is more focused on the ethics of post-trial access, inviting Professor Imis Dai, who established the Steve Biko Center for Bioethics, South Africa, and Dr. Tamam Aroudat, who engaged in access campaign of Medicine Sans Frontiers, MSF. Now, the world situation is drastically changing to overcome this pandemic. As far as we can foresee, something like the global version of the Operation Warp Speed might thoroughly realize. Okay, global supply of effective vaccines, collaborating with COVAX, human rights, justice, and equity frame modern democracy. Today, we wish to listen to the faithful speakers who have contributed to the establishment of democracy in medicine and research ethics. Today, the guests from WMA, Dr. Clover and Dr. Parsapausi, participate again. We wish to congratulate that the WMA received the prestigious Golden Award representing medical professionals combating this pandemic in the world. So, Professor Greco, could you please open today's session?
Thank you very much, Takeo. It's a pleasure to open with you this third meeting. This is second in the subject, and I'm very glad to see all those important people to discuss the things that are very dear to all of us, especially in the situation we are all facing now with the COVID spreading. It's not controlled. We need so many things about it, and I think this discussion about post-trial access has a lot to do with this ongoing epidemic that unfortunately will not be the last. So I pass back the word to you and Kyoko to proceed. Thank you.
Thank you, Dr. Greco. Hi everyone, I am Kyoko Imamura. I am the past president of the IFAP, International Federation of the Associations of Pharmaceutical Physicians and Pharmaceutical Medicine, and also its Japanese National Member Association, JAFMED. Today, I'm honored to support moderating this seminar, and because the ethics has been the most important agenda for IFAP, and Kyoko, as you know, the most powerful member of our ethics working group of IFAP. So I'm really happy to help you your discussion. And then I found that many of the participants today also attended the last week's seminar. So we are already kicked off and shared most of our concerns, and we are delighted to have these inspiring discussions. Okay, so let me invite our speakers. Today, we are going to have two presentations before we have a short break to go into the second part of our seminars. First, let me invite Dr. Imis Dai, Professor Dai. She's going to touch on the ethics in vaccine allocation in developing countries. Now, Dr. Dai, could you please start your brief self-introduction first, and then start your presentation. Thank you very much.
Good morning. Thank you. Well, good morning, good afternoon, and good evening, colleagues. I'm going to start my screen share before I do anything. And can you see this?
Yes.
Okay.
It's gone blank now. I'm going to stop sharing and I will start sharing again. And let's see, slideshow. Okay. So now
we cannot see the slide.
You cannot see the
Yeah.
slide. We were
Try
all
showing.
earlier, right? So let's try again. Let's do the screen share. Can you see it now?
It's coming. Yes.
Ah, okay.
It is.
Okay. So please make a slideshow.
Right. Can you see it now?
Ah,
Yes,
it's now.
very good.
Perfect. Perfect.
Excellent.
Thank you.
Okay. Thank you so much. I'll greet everyone again. Good morning, good afternoon, good evening, colleagues. I'm Professor Ames Dye. I established and directed the Steve Biko Center for Bioethics at the University of Witwatersrand for many years, since 2007. And at the end of 2019, retired. And I'm now Professor of Bioethics and Health Law at the School of Clinical Medicine at Witwatersrand University and specialist ethicist in the Office of the President and CEO of the South African Medical Research Council. So currently that's what I do. I want to thank the organizers of this conference for inviting me to do this presentation today. And as you can see, the topic that I've been given is ethics in vaccine allocation in developing countries. So when I look at this, I am not going to talk about micro allocation at individual level or macro allocation, but I'm going, or meso allocation, but I'm going to look at macro allocation, the ethics in macro allocation decisions for COVID-19 vaccine ethics, in particular reference to our developing countries. So by way of outline, I will have to talk on vaccine nationalism and vaccine equity. I will say a few words on global public good. I will highlight a bit of the issues that we have on the African context, and I'll look at two international documents that actually call for global vaccine equity and solidarity. One international document is the UNESCO's call in February 2020. This is its second statement on COVID-19. There is a follow-up one that is being developed, and it is being spearheaded by Professor Durso, who is on the panel. So I will not discuss that follow-up one, and I'll leave it to him to bring in if he feels it's necessary. So when we look at vaccine equity and vaccine nationalism, what exactly is this? And I think it's very simple to understand if we really embrace ethics. So vaccine equity basically affirms human rights, and vaccine nationalism denies human rights. Vaccine nationalism degrades the COVID-19 vaccine to a commodity to be sold in the marketplace to the highest bidder, it degrades vaccine, the COVID-19 vaccine, to a bidding and dealing process. And this in itself is unconscionable. It's morally reprehensible. It also denies the post-trial access aspect to research ethics by denying those countries from the developing world that participated in the research, contributed to the intervention. It denies them accessing the vaccines as well. And one needs to wonder whether it's time to actually look at pushing the principle of proportionality, whereby if certain countries contributed a certain proportion towards the intervention, then those countries ought to be given first choice in terms of the intervention when available, in terms of the proportion that it contributed. It's very important when we look at vaccine equity that we must recognize that vaccines must be a global public good. And there are many calls for this at international levels. And vaccines must be accessible and affordable to all. So what is a global public good? A global public good its impacts are spread equitably across the globe without causing division. The manner in which the vaccines have been approached, we can see there's a lot of division. And the fact that the global, the vaccine, the COVID-19 vaccine should be a global public good has actually been denied in this way. A global public good is important when you look at the price. A price cannot be placed on the benefits of these goods. So the principle of exclusion cannot be applied to them. And the use by one individual cannot be allowed to reduce their availability to others. A global public good is not marketable, and the goods and their benefits must be available at negligible or zero cost to all in the global village. And we've seen by the many pandemics that we've been having, and now with COVID-19, which seems to be amongst the worst of all, that we are one global village, that a variant can start here today and land up on the other side of the world tomorrow. So therefore, there are two criteria that determine a public good. It's got to be non-rival in consumption. So consumption by one person must not interfere with the goods being available to others equally. And it's got to be non-excludable. So supplies cannot deny it to those who are unable to pay its market price. And therefore, importantly, there are going to be transboundary implications with most public goods. And because of this, we need, in fact, there's an ethical imperative for robust international cooperation and action towards this context. So having said that, I want to refer back to last year. So we want vaccines to be a global public good. But we already saw very early on, in fact, soon after the second half of last year, vaccine nationalism and reports and concerns of vaccine nationalism coming through in various channels. And amongst the first of these were from Duke University, the Global Health Innovation Center, where they published huge concerns, where they had evidence which showed that rich countries had gone on a shopping spree for COVID-19 vaccines. And this actually then meant that there would be very few vaccines left for low-income countries. When they did their analysis, they were able to see that many of these rich countries that went on the shopping spree were going to be able to vaccinate the entire populations over and over and over again. Okay. While those of us in low-income countries were at the end of the queue and we had to wait our turns. And in fact, the data that they actually put out revealed that several COVAX signatories, and I'm not going to go into COVAX because I know we all know what COVAX stands for, and the mission of COVAX in terms of ensuring equitable access to vaccines being a public good. And it showed that several COVAX signatories, including the UK, the European Union, and Canada, were actually undermining COVAX's pact towards ensuring equitable access of vaccines to all by negotiating side deals for large vaccine shipments. Thereby, this would result in a smaller piece of the pie that would be available to us in the developing world. And towards the end of last year, this was the picture that we saw, where you can see the EU was on the top of the list in terms of its pre-orders, followed by US, Japan, and UK, mostly rich countries on this graph. Currently, what do we see as of last night? The European Commission orders in terms of the supply agreement still is on the top of the list, but it's good to see that COVAX is catching up. And when it comes to Africa, African Union is here as well. While we all see the need for equitable access, if we sit and wait for that the equitable access from COVAX, we're never going to get the vaccines. So many of the regions saw it necessary to actually go ahead and get involved in bilateral or multilateral agreements. And currently, as of June the 9th, we can see the list of countries that actually have fully vaccinated their populations against COVID-19. The share of their populations that have been fully vaccinated. And you can see that these, again, are mainly the rich countries. Currently, what do we have? As of last night again, is 17 vaccines that have been approved by use by at least one national regulatory authority. 7 of the vaccines have been authorized by WHO, and it's available in its emergency use listing. There's 13.6 billion doses that have been secured globally. And the range in terms of prices from $1 to $40, clearly highly unaffordable to most of us in the developing world. COVAX has secured 3.86 billion and it's already shipped 81.9 million doses to 129 countries. Looks good, but it's a drop in the ocean. So vaccines have developed at a very rapid rate in terms of COVID-19. And already in April, by the end of April, 1 billion people had been vaccinated, only 4 months after the WHO actually approved a vaccine for emergency use. And this was only 16 months after the virus being discovered. So many celebrated this. But many of us in the developing world looked at these figures and we said, fine, but who has received the 1 billion vaccines? 75% of these 1 billion actually went to only 10 countries. And you can see in terms of Africa, even up to last night, 90% of countries in Africa are going to miss our urgent COVID vaccination goals. It's really bad down here. And we look at the ethics of vaccinating people that are not really at risk, vaccinating young adults, going to adolescents, while many African healthcare workers are still unprotected, have still not received vaccines. And many have died, and some of us are in our third wave now. So we do have concerns of many dying as well. However, when you look at it, and you look at the high-risk populations, those 60 and over, many 60 and over have not received the vaccines as yet in Africa, while in other parts of the world, consideration is being given, and actually it's being embarked upon to vaccinate the young ones. You know, the situation, our context is, we've had COVID-19 disruptions in Africa, and you may say, well, there's been COVID-19 disruptions the world round. But remember, we started off just like very similar to other developing countries. We started off with huge vulnerabilities, huge strains on our African healthcare, on our health systems, huge economic and social disruptions. And these actually got worse with the pandemic. The gains that we had made on our continent with regard to disease reduction and increasing life expectancy towards reaching our 2030 SDGs, our goals, Sustainable Development Goals, we've actually gone backwards in that as well. So that's the situation in the developing part of the world. We started off with vulnerabilities, and our vulnerabilities have been heightened by the COVID-19 situation. Early on, our African Union decided to have a multilateral approach to the pandemic response, and already in February 2020, put together the Joint Continental Strategy for COVID-19, the Africa CDC put together the African Task Force for the vaccine. And the Africa CDC also, together with the African Union, put together a values framework for the fair, equitable, and timely allocation of COVID-19 vaccines in Africa. This framework was basically a collaboration between the South African Medical Research Council, the Africa CDC, and it involved a consultation, a widespread consultation on the African continent. It drew from African indigenous values and Ubuntu principles. Basically, I am because we are, therefore I am, whereby the importance of the community in African indigenous value systems is emphasized. And it's also emphasized in terms of what it means to be a human person. We have a saying in Nguni, Umuntu, Ngumuntu, Ngabantu. A human being is a human being because of other human beings, and the stresses, the interdependence and interrelatedness of humans. And we could apply that to the greater good for all while protecting vulnerable individuals and groups. And this would apply both for vaccine access and vaccine hesitancy. And we do have a problem with vaccine hesitancy and lack of trust in terms of vaccines, both because of what we've seen at local levels, but also because of us being denied vaccines from, you know, the international level. We have sorry, that wasn't from my end. So we have an African tradition of Lechotla, where all gather under a tree to discuss and exhaust all options where there are issues to be considered. And we likened this to meaningful community engagement within our vaccine discussions. You know, these are great values and principles. And yes, Africa must actually take these values seriously. We mustn't pay lip service to these values, but it's something that could actually be looked on favorably by the world when looking at global COVID-19 vaccines as a global public good. So the framework, once drawing from these principles, came up with 4 foundational values. That's affirming the humanity of others, survival of the community, social solidarity, and meaningful community engagement. And in terms of affirming the humanity of others, basically this boiled down to allocation decisions must be made such that society at large benefit and the common good is promoted. This could be transposed to the global village, where allocation decisions are made such that the global community benefits and common good is promoted through the global, throughout the global community. Survival of the communities, allocation decisions should be based on not only the best available evidence, but should look at the greatest risk of severe illness, etc. And when we look at this, we could look at a global level. Which are the regions that are at the greatest risk? Should we not look at making allocations for these reasons, to these regions? Looking at social solidarity, allocation decisions should consider the bonds unifying communities, their interdependence, etc. And we need global social solidarity, because when we look at us as a globe, yes, we do have bonds between countries. And these need to be taken into consideration. We're all interdependent. And this cannot be stressed adequately enough, because that interdependence is important to take into consideration when we look at the fact that our borders are porous. And we see, as we think we've gotten control, we get variants then starting to move around globally. And in terms of meaningful community engagement, allocation decisions must be trusted. And it is such a pity that some of the COVAX donors undermined the COVAX Pact, such that there emerged a distrust of COVAX in terms of the ability of equitable access for all. So let's just quickly look at our UNESCO document from the 24th of February. Article 2 makes it stresses that the shortcomings in infrastructure and logistics must be taken into consideration. These shortcomings exacerbate existing divides between the rich and poor, and these shortcomings may restrict the access of the low and middle income countries only to certain types of vaccines. And it cautions COVAX not such that its initiative should not breed discrimination, nor create a situation in which donors would benefit from first-class vaccines and recipients, the lower income countries, receive the second-class vaccines. And we're already feeling these perceptions coming through, where the mRNA which really requires attention to infrastructure and logistics and the cold chain, seem to be that first-class vaccine. And the second-class ones, which have shown quite a few side effects as well, are going to be something that the remote and rural areas may have to actually end up receiving. UNESCO goes on further to state that for real equity in global access to vaccine, we need to have a shared ethical recognition of health as a global common good with no territorial limits, as well as new global legal instruments for economic and political agreements and treaties. And it states that these treaties, like the TRIPS, were not designed to manage situations or, like pandemics. It also looks at the issue of the business model of vaccine production, and it highlights the responsibility of the pharmaceutical industries to invest in facilities that are able to produce vaccines of the highest possible efficacy and to facilitate rapid distribution to where they are needed. And it also emphasizes that health must be treated differently from other markets. The Lancet Global Commission in February 2021 also highlighted the importance of the TRIPS waiver and urged governments from all regions to agree to the TRIPS waiver as proposed by South Africa and India. But it also went on to say, additionally, there needed to be accompanying transfer of technical knowledge, and this is for the production and manufacturing of vaccines. It emphasized that this would be in line with the globally agreed target of the Sustainable Development Goal 3.8, which calls for access to safe, effective, quality, and affordable essential medicines and vaccines for all. Subsequent to February, we saw in early May, the world was pleasantly surprised when the US supported South Africa and India. And there was also, between the beginning of the year and now, a flurry of publications on the need for the waiver of the patent. And here in this editorial, you can see the point is made that a patent waiver is right and fair, and wealthier countries must recognize that everyone benefits if vaccine manufacturing is distributed evenly around the world. And it also highlights that Africa imports 99% of its vaccines, and African countries lack the pre-order purchasing capacity of rich nations. And I think for us to actually move forward in terms of equitable access to manufacturing vaccines, not only do we have to remove patent obstacles, but there's got to be this transfer of knowledge on how to make vaccines. There's got to be massive investments in manufacturing capacity. So in conclusion, I'd like to say that to confront this tragic moral bankruptcy inherent in vaccine nationalism, what is required is a coordinated global response, which is founded on unity and solidarity. The WHO has said no one is safe until everyone is safe. It's very important to remember that this applies both to within and between countries. Remember, national borders are porous. The right to health and hence to COVID-19 vaccines as a global public good applies to everyone in the world and not just to the people living in wealthy high-income countries. Advancing vaccine availability by sharing of intellectual property, allowing for technology transfer, and supporting local manufacturing of generic vaccines in low and middle income countries. This would go a long way in ensuring that the COVID-19 vaccine is truly a public good and not a commodity to be sold in the marketplace through bidding and dealing. That demand outstrips supply, even for countries that have purchased in advance, is quite clear. We're seeing that now. Therefore, what is the rational way forward? The rational way forward is that we should ensure that supply is rapidly increased. And this can be achieved if manufacturers and rich countries that back them are prepared to share. Sharing, after all, is caring. And with that, I'd like to thank you for your attention.
Thank you, Professor Dai. We learned many issues for to ensure the equitable access to vaccines, and including the TRIPS waiver and the manufacturing programs. So let me introduce our second speaker, Dr. Taman Alauda. Dr. Taman?
Yes, thank you very much,
Thank you very much.
for having me. And in terms of introduction, my name is Taman Alaudat. I am a physician. I come from Syria, and I have worked as a humanitarian worker for the past 20 years with the Red Cross and with MSF, the last of which is in the MSF Doctors Without Borders Access campaign for the past 2 years. In disclosure, I have actually left MSF and started working in the Graduate Institute of International and Development Studies as of last week. And I currently am the Managing Director of the Global Health Center. And I mention that particularly because while the experience and context that I speak from today is acquired through years of working in the humanitarian sector, both as a practitioner, as a medic, and a program manager, and an advocate in the Access campaign, I'm not representing the official position of the Access campaign, which is in a way liberating, because I have spent a lot of time since this invitation trying to understand how do the ethics of access, the bioethics, affect our conception of access from an angle and point of view, not of an ethicist, but of a practitioner. What I would like to talk about today is, of course, the distribution and availability of COVID-19 technologies, that's medicines, diagnostics, and vaccines, but within a framework of having worked in multiple outbreaks and with many infectious diseases in the past, ranging from cholera to drug-resistant tuberculosis, hepatitis, polio, meningitis, and others. And while COVID-19 is without a doubt a crisis on a very large proportion, it is no less one that shares much of the characteristics of other outbreaks. That is, it stops being only an issue of biomedical disease affecting a patient and becomes a communal, a collective issue that affects larger groups of people. It becomes an issue that engages not only medicine and the medical evidence, but also the politics and the economics and even the values of our communities. The difference here is COVID-19 has done that on a global scale. And rather than having created new conditions, it has emphasized in many cases conditions that have existed before, conditions of inequity and lack of justice and in distribution and position that we have known to exist for a long time, but that have largely been hidden from the public view, especially in Western settings. The first thing that we're faced with, and I speak as a physician who has worked in low resource settings, is the first thing we're faced with in an outbreak is choices, rather than having the luxury of working in a hospital where someone else allocates resources and we're told what to treat or not treat. We are put in a position where we have to make decisions about who gets what treatment because of scarcity. Scarcity creates a largely untenable moral position for physicians who are usually not trained for it. And I doubt that anyone is positioned in a place where they decide who lives and who doesn't. But that is a place we are put in regularly in very low resource settings, and that we have been put in this pandemic on a global setting. So as a practitioner, there are some ethical frameworks that we can try to understand and use. And on the face of it, once we start addressing it, it sounds logical, except that it starts creating contradictions. And I think this is where we are today. The immediate sort of blanket assumption underneath public health interventions in epidemics or in any high burden disease settings is that we have a utilitarian ethics where we are trying to use the available resources to provide the most good for most people. Except the moment that starts being practiced in reality, the moment it becomes untenable. It's not applicable in a health setting. And I'll give you the example. If we were in MSF to provide only the most efficacious and cheapest intervention, we'd end up effectively doing childhood vaccination and nothing else. But we have made different choices, including the treatment of drug-resistant tuberculosis before the last generation of drugs was available at great cost. And the reason is that we cannot think of the situation as static. Treating drug-resistant tuberculosis has pushed the agenda of the disease further. It has made it available, it has allowed us to speak about it, but it also has addressed people who wouldn't have had any recourse otherwise. And it is, from a clinician's point of view, very difficult to adhere to a purely utilitarian ethics. So what else? One is the one we were provided with that includes the principles of medical ethics that include justice, in addition to beneficence and non-malevolence, that we talk about justice. And justice is the one odd one out because it doesn't talk about the relationship exclusively of a clinician and a patient. It talks about the position of medicine in society and talks about distribution. However, it's never been put to a test at this scale, at least not in such a public forum. And this is important because it doesn't talk about biomedicine only. It doesn't talk about need purely. The need is intersected by economics and by politics, by the position of people in their countries, the position in their class, the position in their gender, and so on and so on. So then we are faced with situations where we are both put in a position of responsibility vis-a-vis the health of people that are under our care and have been stripped of much of the authority that remains in the hands of sovereign states that on their own have other interests that compete with those of providing the best healthcare. And this is obvious if we look at some of the statistics. You know, the comical addressing of, for example, the US health system, whereby the expenditure is nearly double the next country, and their position in terms of life expectancy or other health indicators is down in the 20s and 30s. The interest in providing the most efficacious healthcare to the largest number of population is not absolute and is not practiced equally. So we end up being put in a position where there is an extreme inequality in distribution of whatever available resources. And in our case here, the one obvious one is the vaccine. And we end up having to choose what sort of action constitutes the most ethical one under the circumstances. And MSF and many others have, I believe, rightly chosen to address the issue of the TRIPS waiver. And a TRIPS waiver has a merit of addressing an instrument of international norm that restricts access and has a potential to be quite restrictive to the distribution of vaccines. This is a position that has softened, as Professor Dai mentioned. You know, who would have thought that the U.S. administration of all would be one that supports the waiver? What that means in practice is difficult to anticipate, because it's not only about waiving the intellectual property. It is also about sharing knowledge, about sharing technology, about accepting that we cannot really accept an automatic intellectual property on products that have been developed by public funding. It addresses the whole system. And the waiver, if anything, is treatment of a symptom. Actually, it is treatment of a symptom of a symptom. And as we all know, you know, treating symptoms might be necessary, but it never really solves the problem entirely. And by that, I mean, the waiver treats one of the symptoms of the intellectual property regime that we are forced to accept. But the intellectual property regime itself, along with the imbalance of research and development and the allocation of resources, in themselves symptoms of a world we find ourselves in that accepts the commodification of medicines, and hence the commodification of people that live in it, accept the sovereignty of states as a higher value than the health of people, and so on. So we are in a situation where we are contented or forced to contend with treating the symptoms of a symptoms, then the waiver and addressing the consequences of a trade regime that accepts profit on medicines and on people's health is the one viable route we have. But what I will go for now is, for the next few minutes, try to address some of the issues that we have faced that were outside the immediate vicinity of the waiver and the vaccines that have come up in different contexts in the lifespan of this pandemic. One of them is the access to healthcare and our ability to accept massive degrees of inequality among different populations. And here, healthcare, the availability of healthcare itself. It's no secret that the healthcare in North America and Western Europe, as well as other rich countries like Japan and Australia and New Zealand or so on, is by default at an entirely different level than many other poorer countries. Yet we have allowed a course of discussion in the first months of this pandemic to focus on ventilators, on the availability or inavailability of ventilators. When we had ventilators necessary to address 2 to 5%, I believe, of patients in the early stages of the pandemic. So most of the debate about the management of this pandemic before the vaccines became available or were known to be coming has focused on whether the 2 to 5% of the population in richer countries are going to have optimal care. Not that this is negligible, this is important, and this is a massive dilemma, because in the early stages in Italy, the Association of Anesthetists, for example, issued guidelines about how to take people off ventilators if they had less chances of survival, to put people who might survive better. So that in itself has implications that are unimaginable to most practitioners in normal times, to actually take someone off a ventilator and let them effectively perish so someone else can benefit from the same machine. But at the same time, very little mention was done to the fact that, let alone that there aren't ventilators in most of the world, there isn't passive oxygen in most of the world. There aren't ICU beds. There aren't ICU doctors or nurses. That was rarely on the TV, except when it was trivialized and caricaturized, like when someone said, oh, but the whole of X country in sub-Saharan Africa has only 2 ventilators, and one of them is booked, is reserved for the president's family. And this in itself, you know, we could talk about the discourse, the condescending and trivializing discourse, that rather than argue about why would a country have 2 ventilators in this day and age, it was made almost a quasi joke to be put on TV. And that extends to the continuation of that dismissive discourse about countries, including, oh, but Africa doesn't really have any cases. The Middle East doesn't have, we don't see them. This is a disease that has affected Europe beyond anyone else. While fully knowing that there are no diagnostics and there are no effective registration systems that would give us a real image. So we've contented ourselves with dismissing, and it went as far as publications that ask, so what do we need to learn from Africa and why did they not have a plan? Well, they did. The fact that we don't see it doesn't mean it doesn't exist. And in my own experience, despite the lack of numbers, in my country, in Syria, there has been a wave of COVID that has largely unreported because it couldn't be diagnosed. But suddenly you start hearing about relatives who are older, who die vaguely from diseases that no one, that never affected them that severely before. COVID has ravaged through the rest of the world, but we have managed to dismiss it. Now, the next one is the access to medicines having suffered this wave of information and misinformation and different evaluation of information. But then also the diagnostics, the access to diagnostics, the fact that we have ended up with a diagnostic tools that are old. So at least the PCR diagnostics aren't ones that are new technologies. The PCRs and machines and cartridges have existed before, and we have used them to diagnose drug-resistant tuberculosis, among other things. Suddenly their availability became abundant after years and years of trying to make some of them available for other diseases. And this is another contextual issue, is, you know, we are all proud with how science progressed and made available diagnostic tools and vaccines within months, and ignore that same could probably have happened for other diseases, and that it didn't. And here I will go back to 10 years to a significant article, in my opinion, by Andrew Lakoff, who talks about 2 regimes of global health. And he talks about a regime of global health that is the global health security, that addresses largely diseases that haven't existed yet and aims largely at the protection of Western countries, rich countries, from the potential of new diseases. And here the response is aggressive, generous, and rapid. And then there is another global health regime, which he calls humanitarian biomedicine, which addresses diseases that are familiar, cheap to address, and yet not addressed, like drug-resistant tuberculosis, like neglected tropical diseases, leishmaniasis, sleeping sickness, and so on, that have needed decades of scarce resources to develop any sort of technologies. In fact, sleeping sickness, which still exists in many pockets in South Sudan, Nigeria, Congo, and others, didn't get a new diagnostic and treatment until they were developed by by non-profit entities like DNDi, Drugs for Neglected Diseases Initiative, which has developed the first non-injectable treatment for sleeping sickness ever. And finally, the vaccines. And here is an interesting point, because as Professor Day said, very early in the process, there was this talk about vaccines being a global public good. Now, there's the point that the Professor Dai mentioned, which is the same countries that proclaimed it a global public good turned away almost instantaneously and started buying vaccines, hoarding vaccines. And we know the statistics, the countries that bought 500% or 300% of what they might need just to guarantee that they will have it early enough. But the view of public goods as non-excludable and non-rivalrous. Well, vaccines are excludable and rivalrous. You know, if someone takes a vaccine, someone else is not going to take that vaccine. Vaccines are not like clean air or clean water, or they have a cost to produce and a cost to, and when they get consumed, they disappear. So begs the question about whether that has served only as a sort of a sloganistic way of making everybody feel good, while the richer countries manage to occupy the market and hoard almost every vaccine, where we see the consequences now with nearly full coverage. And the UK yesterday was discussing whether 12 years old at nearly no risk should be vaccinated. And it's almost completely justifiable in most Western media that this would be a legitimate discussion before healthcare providers have been vaccinated almost anywhere else. So then we are left in a place where governance for global health is scattered between sovereign states that are increasingly protective and look inwardly, and frames that are put outside as unchallengeable and impossible to change, like the fact that medicines and vaccines and diagnostics have to be treated as commodities that go through a market, despite all the imperfections and failures of that market, which needs public funding and needs IPs to protect it. But yet we're offered no alternative and not allowed to think of any alternative. And a few days ago, I've read a definition of governance, because supposedly we work on global health governance, but as you well know, the literature still contests the definition of what global health is and what governance is. So it's a bit difficult. But a sociology book from the 60s argues that governance is making people want to do what is needed, and failing that, making them do what is needed. Governance includes a coercion part implicit to it. There's no requirement of governance to be only democratic or only benevolent. And the problem here is not only making people want to do something, but to do what is needed. And the decision on what is needed is taken by a very narrow strata of managerialist class in the global health, by philanthrocapitalists and billionaires, and by civil servants who owe their loyalty to their next elections before the health of the people in the rest of the world. And that governance, if we do not think that it has left much to be desired under the current pandemic, then we need to reconsider what we think of as success or failure. This is particularly interesting because not only because we knew a pandemic will come. I've worked in 2005 in Indonesia when the H5N1 was going to be the next pandemic, and then in 2009 when actually H1N1 was a pandemic. We've seen SARS happen. We've seen the Middle East respiratory syndrome happen. We knew a pandemic is going to come, and arguably we haven't been prepared. But not only that, we are in a health crisis, a global health crisis that has global implications, and yet rather than becoming an equalizer as we were promised in the beginning, it has become another reason for deepening the inequalities that are affecting people. The inequalities as a result of the COVID itself, but then the others that we haven't yet started exploring that include all the other mortality and morbidity that has happened and is happening in the background and is ignored now because everybody's paying attention. All the unnecessary child and maternal and infectious disease and non-communicable disease deaths that have even less access to healthcare. So from a position where we as practitioners have to function in this system and still be able to go, and have a good night's sleep, hopefully some of the nights at least, there is a difficulty in accepting that there are many days where we have to actually deal with the symptoms of the symptoms. We have to go and pretend that the TRIPS waiver will solve everything. And there are days where that stops being enough. And I wonder whether we could have an argument one day about an ethical decision that accepts the basis of global health being vertical, run by the West, continues legacies of power and inequality, and owes its allegiances to member states rather than people. We might need to answer those questions faster than we think, because now we are dealing with a single virus with a single potentially vaccine to deal with it. And we are struggling to find a solution. In 20 years, we will deal with a climate crisis that will make many other diseases differently endemic, will have no single vaccine to deal with it, and probably be much more expensive and create much more inequality. So I thank you very much for having me, because this is a place where we can hear the ethicists guide us. And I have very much in my career benefited from listening to people tell us how to think better about the ethics of our practice. Thank you very much for having us. And I give it back to you. Thank you.
Thank you, Dr. Taman. Chieko, would you like to lead the discussion?
Yes, there are only 10 minutes discussion time. And thank you very much, Professor Dai and Taman. A very valuable talk for the equitable access to medical resource, many kinds of resources, not only vaccine. And we Japanese have to recognize shameful government attitude to buy top vaccines for nations, and instead of low prevalence comparing Brazil and many other countries, African countries and European countries. So we have to discuss this kind of point. But before the discussion in depth, I would like to invite Dr. Luli, because he cannot stay until the end. So his citizen group are very much engaged in this kind of equitable inequity in the world. Dr. Luli, can you speak now?
I can, and thank you, Kyoko, for giving me a chance to say a few words. It's very, very difficult to say anything that can add much, or certainly not to top what we've just heard from our previous speakers. Really extraordinarily well put together, beautifully stated, eloquent, and unfortunately mostly unheeded. Really a beautiful set of comments, and I want to thank you for that. I only have a couple of things to add because so much has already been said. I think on a personal note, what I found so frustrating about all of this is that this end of the pandemic, if one can call it that, and I don't mean to, but this so-called end, and I'll end with a comment on that in a moment. This so-called end or ending of the pandemic is exactly the ending that many of us saw coming down the tracks 1 year ago. This seemed like a virus that was maybe unusually susceptible to vaccination compared to, say, HIV. It seemed that the concerted attention of the scientific establishments around the world would be able to produce something. And indeed, within a relatively short period of time, it has. But it was equally predictable, or perhaps even more so, that we would wind up in a situation in which some people who had only limited need for the vaccine would wind up with it. and those who clearly would need it would wind up without. That is exactly the situation that was predictable a year ago. It is exactly the situation in which we find ourselves today. And it really speaks poorly of really humanity as a group that with all of this concerted attention of almost literally every person around the world knowing about this going on, that we've somehow failed to come up with a solution that is much better than what we've had in the past. Yes, there have been some signs of progress in COVAX, a recent announcement just yesterday by the Biden administration of another 500 million doses. Yes, those things are admirable. The endorsement of the TRIPS waiver by the US also helpful. But at the end of the day, we find ourselves where we usually do, which is with the haves having and the have-nots not having. And that's just exasperating to see the same play taking place repeatedly. The second thing is, I'm not an official ethicist the way some other people on this call are, but I've taken part in a number of these debates over the years. Sometimes these debates are theoretical; they're about principle, but this one is not merely about that. This is a debate in which literally life and death is at stake. I think what we should call, a global misallocation of vaccines, a public health malpractice has taken place, and the price is not paid in principle, but it is paid in lives, likely in the hundreds of thousands, probably in the millions. And all of these tiny little debates, say in the United States, over whether vaccination should be, for 65-year-olds or 60-year-olds, or whether frontline workers should go before healthcare workers, are so trivial in comparison to this global misallocation of resources that is just extraordinary. This is the big debate. This is the true injustice of this epidemic, and it's the same one we've seen taking place for years. The final thing I'll just say is, here in the United States, we focus a lot on our so-called newspaper of record, which is the New York Times, and it's done a pretty wonderful job, I think, of covering this pandemic with a lot of personal stories, very well done statistical analyses that have appeared every single day, and indeed a section that was devoted to the pandemic, running 6, 7, 8 pages every single day. On the weekend, a special kind of social piece called At Home. And just this past week, the New York Times has decided to do away with those sections. And I'm not here to say that that's wrong from a journalistic point of view. At some point, you can't do it forever, right? But I believe that, in some Western countries, the perception is growing that somehow this pandemic is ending. It's just not so. In some countries, and a number have been mentioned in the Middle East, for example, this pandemic is just beginning. And the self-satisfaction, I think, of people in the West about the accomplishments of science, the occasional gestures in favor of vaccine availability, just really do not take that into account. So I suppose that all paths forward begin with a conversation, and I suppose that this is one of them. And let us hope that when the next pandemic comes, because it surely will, we'll do better than we did this time. Thank you again for inviting me.
Thank you very much for your comment. And so next, Professor Macklin, and then Dr. Parsi is raising a hand, and then we would like to have a break. So Professor Macklin, please.
Yes, I want to thank both speakers for excellent presentations. And I started formulating my brief comment and question before I heard Dr. Aludat, but now I have to add him to it because of his seconding and very interesting and thoughtful remarks. So I'm in total agreement with the points that both of you make, and I won't rehearse any of these. But one thing that was, and the comments were largely, certainly in Ames Dye's presentation, understandably focused on the role of governments and nation states in a global pandemic, appeal to international documents, UNESCO, etc. My question, and Dr. Aludat just touched on this very briefly in a comment, what about the private sector? Big pharma in this world stands to make billions and billions in profits. And they've already made billions from profits in all kinds of other contexts. The next big one coming along is this recent scandal of the FDA having approved a drug that was for Alzheimer's disease that was found not to be efficacious. And there's of course, lots of money to be made there with all the people who are over a certain age. I'm one of them. So big pharma is a player as a vaccine producer. And there's no way to coerce big players in private industry any more than there is to coerce nation states. But why not call for wealthy, profitable industries, not only pharma, but especially pharma at the time when its profits depend upon the sale and future sale of vaccines, to contribute to the needs of the LMICs, the lower and middle income countries in the COVID pandemic. Thank you.
Thank you very much for your mentioning a very good point. That is very important. Oh, okay, so please, Dr. Parsi, please, your comment.
Maybe Tamam would like to respond directly to Ruth's question. I'll be happy to let him first comment on it.
Thank you, because I think, look, in the same spirit of pragmatism, we can't wait until every problem is solved because people's lives are on the scale. One thing is, how do we deal with today? And there are things that have been informed about and talked about absolutely clearly from the beginning, including how can we give billions and billions of dollars and euros as subsidies to pharmaceutical companies without demanding of them anything but vague promises of access. In the South, this meant, in the global South, this meant unaffordable prices because they get to set the prices. But even in the global North, this meant that the taxpayers are paying the price twice. They have paid them in subsidies, the pharmaceutical companies, and then they are paying them again in prices of vaccines. It's hard for me to conceive, and I don't come from a democracy, but when you are in a democracy, how do those things come to pass? And what sort of dogma allows this to be normal? But that's beside the point. There can be conditionalities on public money. The protectionism in the name of we can't sacrifice the economy for the pandemic only is too thin to hold that long. So that didn't happen, but there were very good calls, and governments should be held accountable for the billions they expended on subsidizing pharmaceutical companies without demanding solid and clear returns in terms of access conditionalities. The second question for the future, at least in my view, is, are pharmaceutical, we like market or not, capitalism or not, is it viable for the world to put our collective health and survival in the hands of CEOs whose primary goal is to increase shareholder profitability? Is that a sustainable way to go forward? And that is a significant question. I have an opinion that no one's probably interested in, but this is a debate that has to be had. We can't just sacralize the profit and the market to the extent that whoever dies, dies. And then we end up with the argument on whether, Boris Johnson did say, let the bodies pile high, or he didn't exactly say it. Doesn't matter if he did or he didn't, because every other government acted as if they are saying it when they have given almost free hand to the market over the health of their own people.
So thank you very much. It's okay to. So there are many things to discuss. So okay, so I will pass to Dr. Parsi.
Thank you, Chieko. And because I have to log out soon as well, I was just going to quickly thank you again, Chieko, for having me here and inviting me. This was an interesting and very good and rewarding experience. I would also like to thank our two speakers today, Tamam and Amos. I appreciated your presentations and agree with you. And I also would agree that lifting or waiving patents of vaccines is not enough. It doesn't suffice. We really need the knowledge transfer of the manufacturing. It's probably even more important. So that's something I would absolutely share. But I took a lot of notes, especially getting back to our thoughts around the Declaration of Helsinki and SIOMS, tying back into the discussions we had last time. And Ruth, highlighted the differences between the SIOMS and DOH guidelines with regard to this specific paragraphs of post-trial access. And Chieko, we also took note of your proposal, how communities should probably be also included in this, not just the individual trial participants. And this post-trial access is really a matter of extreme importance, which has to be done before the beginning of a research. And the community engagement should really also be discussed, or at least we should look into that if it should be discussed beforehand, and that should involve all the different stakeholders. That would be sponsors, big pharma, industry, developers, investigators, the trial subjects, but also governments. It should involve all these in order to get to a fair and good outcome, and to sort of make the trial also after the trial has been completed a success. So this is all something we will need to negotiate and discuss again once we discuss the clinical trials documents. And I'm referring more to the DOH because that's a WMA document, and this is something we probably look into soon again. And we heard the differences to the SIOMS guideline. This is all information that we will certainly look into again, and that's something I will also forward to the ethics committee, that might be something we might want to look into. So again, thank you so much for having me here, for giving me this opportunity to say a few words. And I took a lot of good thoughts from this discussions, which I also feed back to other relevant experts from the community. Thank you so much.
Thank you very much for your very kind comments. And we would like to continue discussion with you. And I would like to have a next opportunity. Thank you very much, Dee. So, okay, the time is, Professor Dai wants to say something. So this is the last comment of the half of this session.
Yeah, thank you so much. And thank you so much for the comments, Ramin and Ruth. To go back to Ruth in terms of Big Pharma not being given emphasis, the Article 3 of the UNESCO document that I presented does emphasize the need to actually look at that business model. There's got to be change to that business model. And it also emphasizes the responsibilities of pharma that have to actually materialize meaningfully into action as well. So yes, while presenting a general overview, pharma was included in the discussions. You can't leave out Big Pharma in terms of the culprits they are as well. And what I think we've seen with the vaccine, more especially the vaccine nationalism and the bilaterals that have happened, is there's mischief all around. There's mischief from the high-income countries, their governments, and there's mischief from pharma as well. And perhaps it's time for countries, governments in the developing world to say to Big Pharma, we're not going to allow you to do any clinical trial here unless there is that promise or that undertaking that we will have access to the interventions, not only for those that were involved in the study, but also to our populations that participated in some way or the other. And I think this needs to come from our government levels. So we need commitment at that level as well. Thanks, Olga.
Well, thank you very much. So there are many things to discuss, especially we have to collaborate with the pharmaceutical companies, and we wish to change the previous policy. So after experience of this COVID-19 situation. So, okay, we will continue the discussion after listening to the Professor Greco's lecture, inviting Professor Greco's presentation. Are you ready, Professor Greco?
Yes, I'm ready. Let's see if my screen is shared easily. Just 1 minute, just to see. Yes, can you see it?
Okay. Yes.
Let me put it in the full. Okay. Yes.
Okay. Perfect.
Okay. Let me start by thanking again the Japanese part of this very interesting seminar, and especially Kyoko and Takeo. The Brazilian Society of Bioethics is proud to be with you in this event. I think is very important to all of us. So what I'm going to talk now is maybe it's just a continuation, of course, of what Amy said very well, and what Ruth last week and Peter Lurie spoke today. I think we're facing just a tip of an iceberg that affects us all. But I'm going to try to make it clear when I start talking. I have no conflict of interest to be declared in this presentation. And I have some hypotheses. And I'm going just to name them. Research has to be relevant with social value. We need to have international ethical guidelines to be followed. In clinical trial, access to best proven preventive, diagnostic, and therapeutics must be provided without double standards, including post-trial. Results of human research must be translated into public health access. That's going to be my motto today. And access is even more important, not exclusively and urgent in public health emergencies. And we're talking about the patent exception for COVID products must be issued. I'm going to talk a little bit more about that later. And my second hypothesis is access post-trial as a right. I argue that obligation to post-trial access to products and care is based on many ethical principles. Beneficency, which requires that the welfare of participants be actively promoted. Non-maleficency, that requires that the welfare of participants not negatively affected due to interruption or no access to efficacious products. And of course, maybe the most important is the principle of justice, being reciprocity as part of it, and also distributive justice. That's a notion pertinent to situations that call for the fair allocation of benefits. That are two hypotheses I'm going to discuss now. The first question, and I think I was trying not to make so much about discussing the post-trial access after trials. Because my main point, and I'm going to put myself who I am now, I'm a physician, I'm an infectious disease person. I have been dealing with pandemics, at least 2 of them I have been very much involved. The first one was HIV/AIDS, of course, that hit all of us and still hitting our country, and now COVID. So my point is much more the public health situation than specifically on the very controlled clinical trial. But anyway, I'm going to show you what some documents said. I think Ruth mentioned some of them. I'm start with SIOMS 2016 in relation to clinical trials. It's on guideline 1, guideline 2, and guideline 6. UNESCO has a lot of things, and was mentioned by Ames. One of them is sharing of benefits at Article 15. The 2008 UNAIDS WHO guidance document that Ruth and I participated very strongly in that, and unfortunately it has been succeeded by a very much laxer document that was just released. The 2010 WHO guidance on the ethics of tuberculosis, I think that's a very good document because it speaks a lot about public health access. And the 2013 Declaration of Helsinki, item 34, on post-trial access, I think is a very lax proposal. And I'm going to show you a little bit of developing country position, and that's the 2012 Brazilian Research Acts Commission, 2 resolutions, 404 and 466 on post-trial access. And I'm questioning, is that a dated discussion? Because I think the main focus of all of us must be to ensure access to healthcare to all, and not only in COVID, but I'm going to try to convince, at least convince myself that I'm in the right track. The SIOMS 2016 guideline 2 is a little bit lax about post-trial access because it says that as part of their obligation, sponsors and research must also, and I don't like this wording, make every effort. It doesn't mean really anything. In cooperation to make available. It's make every effort and to make available. It's not very clear what we're really saying about that. That's the first thing. And then guideline 2 does not specifically mention post-trial access, but in commentary, it says that's as part of the obligation to transition to care after research, researchers and the sponsors may have. Again, the verb all the time is not must, is not have to, it's may have. May every effort. So I think it's a very, not a strong position related to post-trial access. On the other hand, SIOMS 2016 guideline 1 may be understood as an added protection for post-trial access because it says, and I think that's the most strong stance that they make is that scientific and social values cannot legitimate subject and study participants or host communities to mistreatment or injustice. I think we have to keep an eye on this, specifically on injustice. The SIOMS guideline 6, again, I'm not going to go through all of this. It's a very busy slide, but of course, if you need to have it, it's going to be at your disposal. In commentary, it says again, may have to provide continued access to interventions, but it says also that sponsored research may no longer have an obligation to provide continued access to study interventions that has demonstrated benefit when it becomes available in the public health system. And worse than that, it says that maybe sponsors, researchers, and community members may agree before a trial starts that this intervention is going to be provided for a predetermined period of time. So it makes everything very easy for you, not providing exactly what people really are going to need. The UNESCO 2005, sorry. It's very interesting too, because Amy's mentioned that, and it's a document that we think is very important, but it says a very lax thing again, because it says sharing of benefits. Benefits resulting from any scientific research should be shared with society as a whole and within the international community, in particular with developing countries. That's very good. But unfortunately, it says that benefits may take any of the following forms. Any could be any of them. And one of them is provision of new diagnostic and therapeutic modality or products stemming from research and access to scientific and technical knowledge. But if I want to interpret it different, I say, well, I'm going to choose two or three of these, and I'm going to be all right with the sharing of benefits, like capacity building or support for health service. In my opinion, benefits should include all of the following forms, at least some of them more strictly. And this is one of them. Provision of new diagnostic and therapeutic modalities or products stemming from research. The UNAIDS 2008, unfortunately, I said this has been succeeded. It's very interesting because on benefits, it speaks very strongly for benefits for people that are participating. And in the end, it says that some of the activities related to the conduct of HIV, biomedical HIV prevention trials, which may benefit those who participate, may actually be rights. That's a good point. That was in 2008. Or may should be, must should be, of course, it should be rights, but it's good for the time of the document. And now we come to the Declaration of Helsinki that I have very many criticisms. I have spoken with that many times. In 2000, I participated in Edinburgh. 2008, I was in Seoul. I was not in Fortaleza in Brazil for the 2013, but it's some of these things is very interesting because in 2000, for post-trial access, for the first time, it was very strong language. Every patient entering the study must be assured of access to the best proven prophylactic, diagnostic, and therapeutic methods identified by the study. This has been changing in 2013. It says that in advance of clinical trials, those people should make provisions for post-trial access for all participants who still need an intervention identified as beneficial. This information must also be disclosed. So the difference is here. Should make provisions in the new one is different from must be assured. So it's not as strong as it was before, and there was a big discussion between 2000 and 2013, and I hope that the next Declaration of Helsinki, hearing all these things that we have been saying and people have been saying and what's happening with COVID, maybe you could put in stronger language as it was in 2000. This is a very important document. It's the 2010, again from WHO. It's on ethics of TB prevention, care, and control. And it's very strong. There's one list of things, and I think Ames mentioned that about when should we permit trials to be done in our countries. It has a list of things that if you don't follow those, this biomedical trial should not be performed. And I just highlighted two of them. When agreements have not been reached among all research stakeholders on access to medical care and treatment, and when agreements have not been reached on responsibilities and plans to make trial products, drugs, other treatments, or preventive measures that prove to be safe and effective, available to communities and countries where they have been tested at an affordable price. It's a document, belongs to WHO, people have not been following. It's not even very much quoted by WHO, but I think it's a very important document. It goes on and says that access to care for all, the obligation to provide access to TB service. Do governments have an ethical obligation to provide? Yes. And they mentioned the WHO Constitution and the International Covenant, the ECOSOC from UN, on basing this, the need that access, universal access to TB care is grounded in their duty to fulfill the human right to health. I think it applies exactly the same to COVID-19. And in the same document, obligation means that TB care should be provided for free. Yes, that's specific for anti-TB drugs, but why not for other drugs, for other diseases that we have a lot of them? And I'm just going to mention this now. COVID-19 came not as a substitution for the other problems that we have. It's an add-on. Even if it disappears, we're going to have a lot of things to take care of, and I hope we can have 3, 4, or 5 meetings like this with Sheikh in command. Again, in 2010, it says the research results should lead to technology transfer. That's exactly what we have been saying now about COVID. And the research protocol should provide attention to how findings will be translated into public health policies. So what we have been discussing in South Africa, in Brazil, in many of our developing countries, or underdeveloped countries, that's exactly what we need. It's difficult because the pressure from the big pharma, the money that's involved is very hard for people to counteract. And I think we have to be part of this counteracting. Now I'm going to tell you a developing country position. I think it's a case study that's very interesting because I'm talking about the Brazilian Research Ethics Guidelines and the Unified Health System, what we call the SUS in Brazil, that's completely public. And that may be a point that I'm going to make. And I'm going to remember just one point here that's in 1st of August, 2008. You've seen the down here. That was exactly 2 months before the 59 World Medical Generous Assembly that changed the 2000 Declaration of Helsinki. Brazilians anticipated what they would do, saying 2 things. First, Brazil was proposing to take out all the notes of glorification related to the use of placebo and post-trial access because they weakened the rights of the volunteers to access to health, keeping the same enunciation from the 2000 version of the Declaration of Helsinki, that I'm going to not read all of them, but it's especially in relation to access to healthcare, saying that everyone at the conclusion of the study should be provided with the best proven prophylactic diagnostic therapeutic method identified by this study. That was very interesting because, of course, as we have said, and all people know, the Declaration of Helsinki is not binding. It's a very good document, very important, very respected, but the countries, if they can make it even more strict, the better. And that's exactly what Brazil did at that time. And in this resolution, it was included to propose further discussion like access to health and to the products that have showed efficacy, not in the clinical trial, but to all who need them. And of course, this was embedded in the new resolution 2012, when we say that at the end of the study, the sponsor must ensure to all participants access free of charge and for all the needed time, the best prophylactic, etc. So what it's saying here is that there's no time limit. If it shows to be effective, it's part of the project. People participate on that, they have to be access to that independently of this getting to the public health system or not. I think Brazil is the only one that has such a strict position. And of course, when this happened, many people said that big pharma would not come to Brazil anymore. They come to Brazil. They change that when they come to Brazil. It's different from other countries because for them, the important thing is to sell drugs. If they have to give one piece of the money that they make to still make money in the countries, that's what they do. And Brazil was a good example. I really naively expected that many countries would follow that. It didn't happen still. The universal public health system, I think, is the paramount importance because that's what we expect all over the world. And there was mentioned, I think it was Peter Lurr or someone else mentioned about what's the public health system in the United States is amazing bad. And in Brazil, that's a country that has a lot of difficulty, disparity that I'm ashamed of. We have a public health system that includes everybody. 210 million people can have access to them. And the AIDS epidemic was a good case study that happened exactly because we have this system. But this is just a glimpse what is the public health system in Brazil, and the numbers I'm not going to read it, but I'm saying that it's everybody has the right to access the public health system, but some people have also private insurance. But from the 210 million people of Brazil, 3/4 of the population are cared exclusively at the SUS, that's the public health system. And that's the dimensions is amazing. The human milk bank, I think, is the world's largest. Organ transplants is one of the world's largest also. We fund 90% of preventive vaccines. 80% of treatments in the oncology is funded by it, and all antiretroviral drugs and lab exams are funded by the system. And including the hepatitis treatment with all the protease inhibitors and new antivirals that are very expensive. And very interesting, everything is funded exclusively by municipal, state, and federal taxes. So that's a very important thing. Of course, we're under the risk of this all being destroyed with this all the new liberalism and situation that we're facing in Brazil today. It's a successful example. We are at risk, of course, but I'm just to show you what Brazil could do with the HIV control. That's 2009, but it's exactly the same in 2020. If you see here, Brazil has the same prevalence as North America and Europe, 0.4% for the general population, in a situation that's even more complex to have all these medications. And just to remind you, in 2021, Brazil makes 21 antiretrovirals available to everyone who needs it, and half of them, or a little bit more, is produced by local public laboratories. So I think it's a very interesting example that if we really have a political will, we can do things even in situations of disparity as we have here in this country. And just once, Brazil issued a compulsory license for one drug from Merck. The price decreases from $1.45 per tablet to $0.6, and it's made in Brazil since then. And that's just an example. That's a sample what is a big economy, a big country. Of course, you know that I'm here in Belo Horizonte. That's in the middle, 400 kilometers inland from Rio and São Paulo, and a little bit farther away from Japan. What I wanted this slide for is just to show you today, Brazil has 17 million cases of COVID-19. We have an acceptable rate of death. We have almost 500,000 people have died from COVID-19 due to many bad things that had happened in this irresponsible government that we have. They negated the epidemic. They took them a long time to decide when to buy vaccines. And now Brazil has 328 new cases per million. If you compare to Europe, that's 60. And as Peter Lurie mentioned, many countries are thinking that the epidemic is going to be controlled in many countries. A few countries are saying that in very little time we're going to have it controlled. But we are not talking about the world. We're talking about some countries that share the most part of the money and access to vaccines in the world. And Brazil now has 14.6% of the population vaccinated with 2 doses, even producing 2 of the vaccines locally. At least it started producing 2 of the vaccines locally. And the one thing that's very important, again, is they decided to guarantee sustainability. It's not only, we're talking here about HIV, and the same about COVID and other diseases. We need technology transfer. We may start using the flexibilities allowed by TRIPS. It's not enough, but to use Doha Declaration. And as I mentioned to you, Brazil just once issued a compulsory license. But now, of course, we are in another situation that relates to post-trial access. He is discussing TRIPS 1995 and even Doha Declaration, because even if you can use Doha's declaration with the compulsory license, it's almost impossible to do that in an urgent situation, because the red taping, the difficulty to access everything that we need to produce anything, drugs, device, or vaccine, the big pharma makes the most difficult way that for us to have access to that. So it's a good thing that in 2020, the proposal that the WTO started very clear by 2 countries that participate in the BRICS, South Africa and India. Brazil in the beginning did not participate on that, but now finally they decide that they are going to be part of it, maybe because the United States has decided to do that also. It's not, and it should not only be for products developed to confront COVID, but it should be like it is in the proposals from South Africa and India. That's temporary suspension of certain provisions that include copyright, industrial designs, patents, and undisclosed information. Because with that, it's possible for many countries that have well-prepared, well-equipped laboratories, they could start producing very soon. And the other thing that I have been fighting for is that this start of the discussion of this temporary ban must be continued to discuss again what does really mean TRIPS. Should it be applied the same as they apply for consumer goods to health? Of course, I don't think it should. So maybe that's a good start. We suspend the waiving and hope that after the end of this pandemic, we could do the same for other diseases that affect us very much. And in this situation, Brazil had a position, and I can provide it to you, of the Brazilian Society of Bioethics with the Brazilian Association of Collective Health, the Brazilian Center of Health Studies, and the United Network for supporting the not patenting of products developed to confront COVID-19. Was in February 2021, just after the discussion came up of the proposal from South Africa and India. And Anne mentioned about that. She mentioned one of the documents that was approved by UNESCO. There's another one in discussion. The draft is being discussed, aiming at issuing a joint statement from UNESCO ethics committees with the objective of ensuring equal access to vaccine to all, and urging for the suspension of patents of vaccines-related products developed to confront COVID-19. It's not still consensual among the committees. I hope it will be consensual because I think with so many people, so many individuals, so many governments backing that up, I think UNESCO has the same, to be in the same boat in this situation. I'm concluding. I'm going to show you I always like this quote from Norberto Bobbio, an Italian philosopher in 1964. He mentioned that the greatest problem of our times in relation to human rights is not anymore to set its foundations, but to protect them. What I'm saying is that we have everything on our hands to do what we need to do. When you say we, I'm being a little bit too immodest, because we don't have. The tools are there. We have to make pressures that they can be used throughout the world, especially in situations that we're seeing in many diseases. I translated to Japanese. I hope it's the same thing. It's written here in Japanese also. And the first conclusion of that is, of course, we need better preventive methods, more efficacious and less expensive drugs, and many more efficacious vaccines. And clinical trials with these subjects can be performed where vulnerability is lower, with the presupposing that if it shows to be effective, it has to be distributed throughout the world. Our researchers should participate in all stages of the study, from the development to the application. And it's crucial to develop universally accepted ethical principles. And if ethical standards are lowered, it will certainly be difficult to eventually raise them. This is a kind of criticism of what is happening with these documents that I mentioned before, that some of them were very strict and now they're a little bit laxer, maybe adapting, according to them, to the new times, for which I do not agree. Decision about post-trial access should be based on principles of justice. And the volunteers must have access to drugs, vaccine prevention strategies, and any other study benefits. And in my opinion, the discussion on access to care and treatment in research is dated. And I think that the endless debates about the rights of trial participants to post-trial access must be substituted with a broader, more difficult objective of providing access to all efficacious product research in public health. And what I have been, it's not my phrase, the next one, but I think it may be for many people that the status quo of inequality must not be an immutable fact, and we must fight for universal access to health, which is recognized as a human right and not as an economic commodity. And just to remind you all, I said in the beginning, and I repeat in the end, is that COVID is just, not just, but it's one more epidemic that we have to face. If you look at this list here, that part of it is written in Portuguese, but there's 15 at least, what people call the neglected tropical disease, that I think it should be called disease that disproportionately affect neglected populations. I think it's much clearer to say that, because many of these diseases that we have here in Brazil, I'm not affected by it because I'm not part of the neglected population. And of course, 2 of them are not included, 3 of them are not included here, AIDS, tuberculosis, and syphilis, because there are some specific programs to tackle that. And in 2013, the World Health Assembly adopted a resolution calling for a world decision to prevent, control, eliminate, and eradicate these diseases. And in 2015, this is very interesting. There's a new document. There are many documents. We have all the tools to follow, to eliminate, or to prevent, or to control most of these diseases, that we have the tools and we have the money, and we need just to have political will to make it clear that people need to be rid of these diseases. And I'm going to conclude with 2 quotes and a tribute. And maybe it applies to us here, because Thucydides in the Peloponnesian War mentioned that said that justice will prevail when those who are not subjected to injustice are as indignant as those who are. I think I'm part of this group, because I'm not that subject of injustice. I'm a physician, I'm a white man, I have a salary, I can work, but I'm an exception in most of people in the world. I think, and I dare to say, that justice will prevail when those affected by injustice are able or emancipate themselves to fight for their rights. I think that's a part of our need to fight for that. In Portuguese, many people use the first one as in empoderamento, the empowerment, that translated direct from English. I think we should use what Paulo Freire used most of the time, emancipation. Empower people. People can be empowered, but we cannot empower people. But people can emancipate themselves to the fight. And one more quote that I'm going just to repeat and just be second to. I'm going to use José Martí when he said, "My country, not my county, my country is humanity." So maybe that's a way that we now together in this international discussion may think about that. If we don't save all of them, we're not going to save ourselves. And my tribute is to London 2012 in the opening ceremony. The homage that they used was the national health system. And the people that were part of this opening ceremony were the nurses from the national health system. I think that's a very interesting way of saying that it's important to have it. And very recently, that's COVID-19, that's an airplane from one company from United Kingdom saying, "Thank you very much, National Health System." I think that's, I can finish with that, saying thank you for all of you. That's the symbol of the Brazilian Society of Bioethics, and that's my address. Thank you again, Kyoko. Thank you all for listening to me at this time, especially in Japan. That's almost, what time is it there now? Almost midnight. Thanks very much.
So thank you very much, for Professor Greco, for your powerful, excellent presentation. And we learned so much from Brazilian experience to battle with difficult situations, and we learn there are many things that bioethics can do. So that is we Japanese don't have such kind of experience, but the bioethics and research ethics can do many things. And we have to make an effort. So before starting discussion, I'd like to invite Dr. Francis Clory as a special commentator, because he has sorry, please make mute. There are some noise. Okay. So Francis, could you make a comment, because he's very much engaged in many of the WHO's document, or the WMA also. So please give you a special comment here.
Thank you, Kyoko. Thank you very much for inviting me to participate in this. So just a little bit from my background. My background is in philosophy, and I spent years working on developing ethics and ethics committees, ethics review around the world, and developing programs for education in ethics, biomedical research ethics around the world too. And also I've been involved in a number of the WMA discussions and putting together discussions for the World Medical Association on the Declaration of Helsinki and other aspects there. And also writing WHO guidelines throughout the years, and also guidelines from UNAIDS too, where many of these discussions actually first started with the UNAIDS guidelines that we wrote in 1997 and 1998. So that's where we're come here too. So I'll share my screen with everyone here and just give some thoughts that reflect on last week's discussion here and on today's discussions. And just want to say, over the past year, we've had a group coming from around the world together, also from Japan, but from around the world, and Brazil, discussing and looking at what COVID-19 is on all its implications. And from our discussions last week and from what I've been listening to today, I want to try to take some of those learnings and to see what we can learn from our discussions and what we have come to. And I'm afraid that my thoughts are not so positive at this moment, having listened to the discussion and having seen where the global discussion is going with regard to COVID-19 and where we've come with the Declaration of Helsinki and SIOMS and the WHO guidelines and so forth. I think we still have a long ways to go. So I just want to start here with a quotation from Dr. Guterres, or Mr. Guterres here, the Secretary General of the United Nations, said back in September that the pandemic is a clear test of international cooperation, and that it's a test that we have failed. And the reasons he gives for failing the test is a lack of global preparedness, cooperation, unity, and solidarity. And I think we've seen this. I think we've seen that we have in many ways failed here. COVID-19 has been identified in nearly all countries. We see having 173 million cases to date and 3.73 million deaths worldwide. So we've seen an enormous amount of impact from this virus, and our response to it, although in the beginning we promised that we would cooperate with one another. We promised that we would work together and coordinate with one another. But in many ways, we failed to do that. We've excluded people, we've excluded voices, and we've downplayed work that was very important to be done here. And we've entered into our own silos, and we've gone back to what's comfortable with regard to ethics and with regard to the discussions we've had in ethics, rather than try to go forward and to look at really what the situation is today, not the situation from when UNAIDS began this discussion in 1997, 98, or when the World Medical Association picked it up in 1999 and 2000, or it was picked up later by SIOMS, but really what's going on today and why that the Secretary General of the United Nations found it necessary to say that we failed. And I think today we would say, looking back at September 2020, that we failed even more. The failure has been extraordinary. One of the failures here is just in the very title of the United Nations. We speak about vaccine nationalism. What hasn't been mentioned here too is we speak also about vaccine diplomacy. We in fact use those terms very differently for different countries. And one is as derogatory as the other in a certain sense, but both are present around the world, in developing countries, in high-income countries, in middle-income countries, and in low-income countries. And the solution to this nationalism that has failed is not more nationalism. That's not the solution. Nor is more internationalism, which is based on internationalism, also not the solution. What have we seen at the patient level? Let's talk about the people for a change. Let's talk really at the very basis of what's going on here. We see a reluctance for patients to come to hospitals for scheduled clinical trial visits. We see reluctance of patients, not just for clinical trial visits to come to hospitals, but also for normal everyday care. We've seen a significant delay in patients presenting for diagnosis and treatment across the board, including COVID, but in many other diseases. And we've seen a dramatic shift in pharma and in the public health community towards its response to COVID-19 and away from non-COVID-19 clinical research, but also, well, just clinical care. One of the things that we've seen with regard to COVID-19 is a poor selection of trial cohorts. The Lancet reported just recently that the global collective clinical trial response to COVID-19 has occurred with inadequate collaboration between researchers. And inconclusive research findings from many clinical trials have re-emphasized the importance of high-quality clinical trial research. Our science has slipped. It has not become better because of COVID-19. It's become more politicized, more nationalized, less cooperative in the field of science, less cooperative in the field of data, less cooperative in the field of ethics. And the medical research response to COVID-19, according to the Lancet, has been inefficient and wasteful. Now that's pharma for sure, but that's not just pharma. That's across the medical world that we've seen this. And we've seen an overwhelmingly large number of clinical trials having been registered and done with questionable methodological quality. And the COVID-19 pandemic has highlighted the need for more coordination and collaboration. But how are we going to achieve that coordination and that collaboration? That we don't know. And I think fundamentally, what this pandemic shows us is that there's been a lack of preparedness, not just for this pandemic or for potential future public health emergencies, but it's fundamentally about recognizing that this is this radical disruption caused by a virus, but not only caused by the virus, caused by our responses to it, brings with it requirement for basic changes in how we carry out research and also in how we perform public health. Here in Belgium, we see every night, and literally every hour on the radio, we're told about vaccines. We're told about which percentage of our population has been vaccinated. We're told about how scary it is to go out on the street without a mask. Today I walked through an open air marketplace where you have to wear a mask. People are not silly. People are not stupid. So we've seen with this that, and what we don't hear on our news at night is that our emergency rooms at night are full. Our emergency rooms are full. They're not full with COVID patients. They're full with acute mental illness patients. We don't hear that on the news. We don't see on the news that in Belgium, there's no room in a hospital for patients with mental illness. And there's no room in care homes for patients with mental illness. We never had this situation before. So my question coming to this meeting was, did ethics play a role in the COVID-19 response? And I can only say ethics has played no role at all. Ethics was and has been, for all practical purposes, marginalized. And ethicists lent their support, and I put that between quotation marks. And you can see this in publications from the ethicist, as did the medical scientist and public health specialist, as did our global philanthropist. They lent themselves to decisions largely taken on political, economic, and investment basis. And no more, probably the role of investment has played the largest role in this. And it's not just about high-income countries and low-income countries. We have poor people in Belgium. We have people in Belgium who have no access to healthcare, who have no access to any kind of healthcare. We have poor people around the world. And we're increasing through COVID the amount of poor people in the world. And we're increasing the number of rich people. And those philanthropists who are coming forward and supposedly telling us how we should run COVID have become even richer by doing philanthropy. It's not just the pharmaceutical industry, it's also those who are invested in the pharmaceutical industry. And then who, when they write in the New England Journal of Medicine, write, well, what is your conflict of interest? Too many to name. And that's their answer, and that's accepted by the journals. So why did ethics fail? Well, ethics failed basically because of the structures of power in our communities, in our societies, and basically because of our national governments, and because of our international organizations, which are precedented our national governments. They also failed because of the scientific and public health communities. It's a dramatic failure of science, during this pandemic. And principally because of the ethicists themselves. Because ethics failed to prepare a place for ethics in the public health decision-making. So there is no place for ethics in this public health decision-making. And there still is no place for ethics in public health decision-making. It's not that ethics suddenly took a back seat. It's just ethics never, the ethicists themselves never sat back and thought to themselves, what is ethics about? And why is ethics important to the discussion? And what role should ethics play? And this failure bears with it a monstrous impact for individuals, communities, and our global society. So thank you for listening.
So thank you, Francis, for your excellent comment of the analysis of how ethics can do in this difficult situation. So Professor Macklin raised your hand, and after that, I'd like to invite a comment from Dr. Kloiber to give the speak about WMA's perspective and your very much important activities of the WMA. And also, I'd like to ask Professor Schmidt. Thank you for your coming back, and he is a last week speaker. So I'd like to ask comments from these three people, and after that, I would like to open the free discussion. So, Professor McLean, please.
Well, just a very brief comment about Dirceo's presentation. He made, or you made, Dirceo, an excellent overview of these many international documents, bringing in more than I had even remembered. And it's also, I liked your point about the weakened wording in some of these documents from one iteration to another. And of course, none of the provisions of these various guidelines are binding on anyone, but many countries do state their adherence to the provisions. So my question is basically, are there too many guidance documents? Which ones should anybody, any government or any individuals adhere to? People can pick and choose which ones. And I note for the audience, if they're not familiar with it, that many years ago, the US FDA stated its adherence to the Declaration of Helsinki. But once a revised version of the Declaration of Helsinki came out with specific wording on placebos, the FDA didn't like that because the FDA loves placebos. And so the FDA pulled out and no longer adhered to the Declaration of Helsinki. So with all this picking and choosing, how valuable are these international documents, which say many good things that very few people pay attention to?
So Professor Greco will give you an answer.
Yes. Well, I'm going to confess you that Ruth and I discussed about that before she asked this question. No, that's not true. I'm just joking. But it's such a long time that we have been together in these documents that I think what she says is completely true, and what I have been saying all the time. And that's the reason I put what Bob you mentioned, that we have so many things that are written that what can you do? You can just choose and say, I mean, that's not good for me, I'm going to get another one. And I'm going to take this opportunity to say two things. In the last discussion of the WHO UNAIDS document that was just before the beginning of this pandemic, it was in Switzerland. Ruth and I were there. And I was very upset when someone presented in that meeting one guideline from the National Institutes of Health. We're discussing about the international UN WHO meeting, and someone presented one guideline from National Institutes of Health. So what I mean is that there's so many. And I think the only way out that we can have, Ruth, maybe one thing that Brazil did when they decided to have one specific for the country and just make it what is used in the country, something that they have decided, they put all people together, and that's what is happening here. But that's very difficult because in many places, and I'm going to go back to National Institutes of Health again, most of these projects are international, they are financed by them. So they put whatever they want, and it's very hard for us to go against. I think we have this opportunity here. We have now here, how many people? 46 people. I hope that we can together think about that and see what we can do as a group in all the venues that we participate, aiming at have one document that this could be binding. That could be from the United Nations, as they had so many others. Maybe they're not that much respected, but they could be binding for people to follow them. That's the first thing. And if Keiko permits me, I'm going to show you one thing that Ruth exactly mentioned. Now I'm going to open I'll share my screen again. Can you see it?
Yeah.
Yeah. Okay, that's exactly what she meant. In 2004, 2006, the FDA decided to take the Declaration of Helsinki out because they were afraid that it's going to be very strict to them. And so they open up for people to make comments. Of course, I made comments. Peter Lurie made comments. Ruth Macklin, of course, made comments. They didn't care. They just decided that last year, US Food and Drug Administration adopt new standards of human clinical trials conducted without its advance sign-off in foreign countries. This took out the Declaration of Helsinki, and they just followed the good clinical practice. That's not an ethical document. Peter and myself, we published paper on that. It was in the Lancet. It was in the cover of the Lancet when we said the Declaration of Helsinki, the standard bearer for international research ethics. It would be tragic if the US tendency to arrogantly flout international morals, claiming the Declaration as another victim. That was very good for me. It was a good paper to be, but no repercussions. But very interesting, just a little bit later, there was an editorial in Nature. It was very interesting, was very much against, they didn't care. They do whatever they want because they have, again, Ruth, they have the power, they have the money. We have to keep fighting. I'm sure, I hope I was not too long to answer a very difficult question that you made.
So thank you very much. So Professor Schmidt raised a hand, and so he will speak on this topic, and then I'd like to invite Dr. Kloibert on this kind of discussion. So Professor Schmidt, please.
Yes, thank you very much, and apologies for being a little late today. I still think this is an absolute amazing meeting here, and the debate we had over the last 2 weeks. I can only commend you for having brought all these experts and papers together. Let me just comment on some of the things which were said in the last 2 papers. Ruth is obviously absolutely right about the number of different codes and guidelines which the world has today. In the mid-1990s, Professor Troller from Basel once looked actually at the number of codes which existed at the time, and that is mid-1990s, and he counted something like 300 medical ethics codes in different fields of expertise. So you can probably gather from even that the problems for scientists and experts to actually navigate that mass of documents and know which one was actually relevant for them. And one of the results of that was obviously that the Declaration of Helsinki has become increasingly a point of orientation because of that confusion in the field. So that is a very important point being raised here. The other point, which I think came through very well, and I commend Professor Crawley for bringing up the issue of ethics and the failure of ethics in the current public health crisis. I think what is interesting in the current situation, I feel, is that we have a discrepancy here between bioethics on the one hand, which is historically largely and has been shaped by a Western perspective, the discipline itself, as it evolves from the post-war period and was established in universities and as a field of professional activity on the one hand, and the lack of development of something what one could call public health ethics. That is an area which is underdeveloped conceptually and historically. And I think what Professor Crawley was highlighting here is the lack of recognition that ethics needs to play a part in public health to a greater extent as bioethicists have ever really conceptualized that and engaged with. That is just a comment. And finally, I think the very important point he made in relation to international cooperation, which was obviously of a very, very great importance after the Second World War, and the whole creation of international institutions and organizations from the WHO to the WMA and others are testament to that cooperation. We are obviously seeing a major failure in cooperation and collaboration, and one may obviously ask whether this is only due to populist politicians and that we could say, well, the world had just had bad luck. At the moment when the pandemic struck, we were given a bad hand, so to speak, as far as the international politicians are concerned. But I think that the reality is slightly more complex than that. And what I want to highlight is perceptions of different communities, how they see themselves. Professor Crawley highlighted that there was a failure of science. Literally about half an hour before I joined this meeting, I was in a workshop with top scientists, top virologists, and the perception is a complete different one. It is literally one of complete success. Scientists think that that they have actually achieved the greatest success in this pandemic by collaborating and developing a vaccine so quickly. And what I want to highlight is that there seems to be very different ways of perceiving this pandemic in different communities. And I think this meeting has very much highlighted the issues which are of fundamental importance at various levels of our debate. So thank you for that, for bringing us here together.
Thank you very much for your very important comment. So Dr. Claude, could you give your comment?
Yeah, thank you. Thank you very much, Dr. Kurihara. And first, let me thank you for bringing this together like the previous speakers did. I think it's a very interesting and very important discussion which we have here. And so many things have been said, so that I'm a little bit skeptical whether I find the right words to start to be part of this discussion here. And I would like to do that by quoting an American writer, Damien Barr, who has written a little poem about the corona pandemic. And let me give you just some of his lines, which I think are so important. He wrote, "I heard that we are in the same boat, but it's not that. We are in the same storm, but not in the same boat." And later on he said, "Some are on super yachts and some have just one oar. And I may add, some are sitting on the sun deck and some are about to drown." And what this pandemic revealed is just the ongoing inequity which we are seeing in this world. So it's nothing new. It's the same story that we have seen before. And that is something that makes me think whether we do not have to think about some more fundamental things that we have to change and that we have to address. And there are a few of the observations during the pandemic which, well, don't make me happy in just joining this chorus of bashing the pharmaceutical industry and all their richness and profits they have taken, and praising some of the healthcare systems. No, I'm sorry, it's not that easy. I think there is a failure that is going on for many years, if not forever now, for a long time, which we have not addressed properly at all. Instrumentally, what does that mean? It means, for instance, that our international cooperation is based on agreements which favor money making, but not the people. We have agreements like TRIPS and GUTS, which are arranged around economic systems with the idea that, well, if you allow more profit making, more trade, more business, then everything else will follow and there will be more justice and there will be more wealth for everybody. Well, I think we have learned that this is not that easy and it's not necessarily the case. Doesn't mean that we shouldn't cooperate. Doesn't mean that we shouldn't trade. But the question is whether the ideas on which we have based all those cooperations are the right ones. whether the primacy has to be on we're doing business and then everything will follow, or whether we should ask, well, what is it what people need? And how do we do this in a fair and a just way? But those questions have never been asked. They're still not being asked. And if you look on the very recent past on treaties that have been negotiated, again, those treaties are not favoring the poor of this world or even a fair dealing with those. It is still this mentality of it's us against the rest of the world. And that is prevailing. Is there hope to think that politicians alone will do this? Well, let's be serious. I mean, what we have seen during the last 18 months has not been something for the hallmark of political achievements in nearly no country of this world. Yes, there have some which have been better prepared, but those are now falling back quite obviously because they have missed the opportunity to engage in vaccination and in the next steps. And most other countries, politics has failed. And the Secretary General of the United Nations, Mr. Guterres, is completely right. It has failed. Is that only to blame politicians? No. We had nice papers at the World Medical Association describing exactly the situation that would come up with the pandemic. And we have asked for the pandemic preparedness. But what have we done? Nothing has happened. We have not insisted. We were not standing on the feet of our politicians saying you have to change that. Ames quite rightfully spoke about moral bankruptcy. I think that is a very strong term. It's correct. But on the other hand, would a different behavior fall on a high moral ground in those countries which are in need? Look at the situation in Africa. Most governments there are more interested in engaging in the next little war with their neighbors than providing healthcare to their people. And if the neighbor is not available for war, well, then they use their own people to have war with. And they spend a hell lot of money for that. So I think the underlying problems of inequity which we have are the ones which we have to address and have to continue. We are not getting a quick fix for this pandemic. That will not be possible. But I think we will have to focus on what we do next and how we continue. And there, I think there is a good role for civil society and for scientists to remind our politicians that we need different treaties, that we need a different system for intellectual properties. Just waiving now patents, I think, doesn't make the big difference. We need a new system of how we deal with those properties and what we think is common good and what is not. And that is something that is before us. And therefore, I think there is a role for civil society to engage and to engage more. And there is a role for all of us, whether it is scientists or activists or those providing humanitarian help, to push much harder on our politicians and to remind them that this inequity has to be fought. And that's not easy. Let me just tell you, from coming from a rich country in this world and from a country which on an international scale is pretty well off with the vaccinations. What the people demand and what they charge my health minister for in Germany is not that he is considering to give more vaccine to other countries. They are lamenting that he has not bought enough vaccine for Germany. And that is what they are excusing him of as a failure, not the concerns about third countries. And he indeed will tell you that he has sworn an oath, and the oath was to protect his country, not to protect other countries. So in the thinking of global health and global inequity, I think we have to advance this system really a big step forward. And I think that is the answer to what we have to do in the future in order to really make a difference to what we have seen now. We must get better prepared, but the preparedness has to be on all levels, and it has to be with the engagement of all of us, not only of the industry, not only of the politicians. If we don't all engage, it will not change. Thank you for giving me the opportunity to be with you, Dr. Koyahara.
Thank you very much. It is very much excellent, important comment. That the point you pointed out is just the same as I heard from the Brazilian Society of Bioethics statement that this inequity we are now seeing is not only the situation of COVID-19 pandemic that is existing structure of this world. We have to change this world, just change this system, and we have to discuss to what is a new alternative system. And so Taman raised your hand. The MSF have many ideas of. I know very well that you don't say just waiver of the patent, but you are always seeking for a new system, the change of this system of this world. So could you give your comment?
Yes, thank you. There's a point of obviously a pragmatic point of that comes from an organization, civil society organization like MSF, which comes from the fact that we, historically working on access to medicines comes from the fact that we have patients that we cannot afford to treat, even as a Western, relatively rich organization. That comes from the HIV pandemic and the exploitative way the early days of the antiretrovirals were. But that obviously is one part of it, and we have engaged over the years with many access issues and faced the consequences of the inequities that have been addressed. And in responding to that, there have been directions that debate the necessity for the exploitative IP intellectual property regime, which allows by design and by definition a highly manipulatable system to recreate and reinvest and reinvent medicines that are by definition created to be profitable before being anything else, the exploitation of public resources and so on and so on. And then the demand of poorer countries to work against their own populations by making them enforce IP regimes that aren't of their interest. But it also extends to research and development. It extends to the fact that many of the medicines that get patented are developed publicly and so on and so on. But then if I take my MSF hat aside, or my ex-MSF hat aside for a second, and I try to follow up on Professor Crowley and Dr. Kleiber's comments. Professor Crowley talks about the position of ethics, and again, what is like much of the academic disciplines, there are first way too many directions to be followed usefully in an applicable way for a practitioner or an advocate to do. And I'll just give an example of where the starting position of an ethical argument has been fairly disappointing. A few years back, there was an article in The Lancet, Prasad and Emmanuel argued that we should, in the interest of coverage, and from an ethical point of view, we should promote the use of second-line, less efficacious, more toxic medicines in sub-Saharan Africa. So in that position, the ethical stand was to give people worse medicines because they are poor. And we've tried to answer that. And the fact that this ignores what makes people poor and how is this becoming a double punishment. So for their poverty, they get worse healthcare by design, not by necessity. And that is dressed as an ethical position. So it takes me back to it is the starting point that matters. Dr. Kloiber has talked about equity, and he made the point of the waste and conflicts that are the conflicts in sub-Saharan Africa and African countries that are wasting money. And that is probably technically true, except that reflects a point that ignores the historical context that has put them there, and the fact that they don't buy weapons from outer space, they buy them from liberal democracies that continue to do that. And this, dismembering one inequity issue from the geopolitical context, and allowing this invention of innocence of liberal democracies. In the World Health Assembly 2 years ago, it was liberal democracy, Canada, Norway, Germany, UK, US, who opposed a resolution in transparency. Those same countries opposed the waiver today. There is a consistent acceptance of the imbalance of power as the norm from which we start our moral positions. That's unchallengeable. And it's troubling that this is where we are now, because if we're going to talk about beyond, waiving IP issues at pharma, then at least as someone who has no leg to stand on among ethicists like yourself, I need something that takes me beyond just, it's not only the job of politicians and pharmaceutical companies, it's all of our jobs. When something becomes everybody's responsibility, it becomes nobody's responsibility. And that is very difficult to deal with in any practical manner. So until we have that, then, forgive us if the obvious targets are pharmaceutical companies and politicians, who are the direct harm, who are the ones who are linking aid to trade, who are the ones who are putting profit above all, and who are the ones who are doing it with very little shame and cover now when things hit the fan. Thank you.
Well, thank you very much. So Professor Greco, you raise a hand directly on this comment.
Yes, I want to second Taman, but I want to stress against something that have been said before. I'm not sure if the ethics is not involved in all of this. I mean, maybe the ethical as an institution, but all of us are people that are working ethically, trying to make a difference. And I can say, and I'm repeating what I said about what has happened in Brazil in the last 40 years, when we decide to face frontally the AIDS epidemic. Different from what Taman said, we decided to provide drugs for everyone. We have a problem that many of you have difficulty in accessing, is that we speak a language that you don't speak. If we publish in Portuguese, you don't read. So many things that happen in countries like mine is a little bit different from South Africa when they provide everything in English. But Brazil has been at that time a very good case study example of how to face things with the participation of civil society. And now I'm just quoting again what I said about Thucydides and saying that and I'm going to quote Otmar, but differently. We are in the same storm. We here are in the same storm. But pharma is in another boat. And maybe they're part of the problem, as Taman said. It's very, very easy to, and I do that all the time in Brazil, to blame the government for everything that's happening here. Of course, they are part of the problem, but we are part of the solution. The problem is that we are in a small boat. We have to join together to make the emancipation that I've been saying all the time. That happened. I'm going to use the example again. 1988, Brazil decided to make one only public health system for everyone. Is it fantastic? Of course it is not. But it's amazing that we think a country with 200 million people have one public health system for everyone. So that's a good start. We have to use all those examples from developing countries to say that it's possible. And I agree with Taman. Our biggest target now, this moment, is pharma industry. It's not the only one. It's not going to be a solution if we have all this decided. If we find a way of taking out the TRIPS declaration, won't make any difference now, but it's a good start. I mean, it's a small step toward something that we can do as people together. And here's an example. We have people from many places in the world, but we don't have that power to do it at one time. I think these are the seeds. Every time that Kyoko and myself, one in Japan, one in Brazil, we decide to do things like that, it's a small plant that we have to keep growing, keep watering to see what can happen, even to change the status quo situation. I'm not naive on that. I think it's not going to be easy. It's going to take time. And maybe the COVID pandemic could be another stepping stone, because people all over the world are talking about things that were happening before COVID. All the inequity, the lack of access, the neglected disease, they were there before. And COVID just to put it in the stage. And I think we have to use that now to see that the end of this pandemic is not returning to what we had before. Thanks again, Kyoko. I hope you can take a picture of all of us before the end of this meeting as a historic time. Thank you.
Thank you very much. So if there is any other comments, something for which to say at this last occasion, is there any, yes, Francis, please.
Thank you, Kyoko. Firstly, I want to thank you and all the other speakers for a really good conversation, a really good discussion, and I think very timely and very important. I do think that we have failed, and I think the first place to look when you look for failure is to look to yourself and to look to ourselves here. Where haven't we done the best we could? I think ethics has been, as Professor Schmidt demonstrated in his discussion last week, and we've seen many times, bioethics particularly and medical ethics, most particularly, but both of them have been reactive kinds of practices. And we hear that in the discussions here as well. But we haven't thought deeply about ethics and the relationship between ethics and bioethics. We haven't thought deeply about the role of ethics within this conversation of humankind and the place it should have. Ethics is not the only voice in this conversation. It's not even the decisive voice in the conversation. That's clear. Equity is not the only aspect of ethics. Ethics is much more complicated than that. And having an ethical discussion or discussion about ethics during a pandemic, or within the context of medical research, or ethics within the context of public health and public health research and public health response, I think requires more than just a reactive tenor, and it requires more reflection about what role ethics can play and should play in our societies. And that's really what's important. We need to think about what role ethics can play in our societies. And we need to give a place for that within our societies. And that's something we're learning to do. So thank you very much for a really wonderful discussion. And I hope that we can go forward with this and we can continue to advance it in the future. Thank you.
Thank you very much. And if if it is possible, I'd like to ask Professor Kimura's comment. It's possible? I'm sorry to ask you always the comments.
Okay, no?
Yeah, okay. Please. Is it possible? Yeah.
Well, thank you very much indeed. What a wonderful symposium for 2 days since last week. We really appreciate for all the speakers, very important comments. I think we are not having like this, conversation, open conversation in Japan yet. I think I really enjoyed, and we seriously, considered what is the basic starting point of bioethics after the war. I had an impression that kind of thought that we have to go back to the fundamentals. We have to go back to the roots of the ideas of the new medical ethics since 1947. I have, last week I mentioned about my thesis on the experience in Japan. And I think Dr. Schmidt has written, you have, I think Dr. Schmidt has read this book. I have written the issues of the Japanese the bioethical experience during the wartime, which has very negative impact to all the Japanese medical field. And then all the important, I recommend one of the very important book in thinking of this bioethical development since after the war is, I'm now having this Ruth book here. This is, I think, the bioethicists nowadays must read this very important book based on some very good analysis on cultural elements. And she mentioned the cultural diversity and the search for ethical universal in medicine. Ethical universals in medicine. We have, in this time of COVID-19, I think we need to stick to the fundamental issues after the war. And then we have to review all the development of bioethics during time of this COVID-19 to find out new way to proceed. I think I have got many interesting advice and suggestions during this conversation. And I really appreciate for all the people's participation with very good analysis, insight, and energy. And thank you very much indeed. I really appreciate as a Japanese bioethicist to have this very important contribution from all the people in the world. Thank you. Thank you very much.
Thank you very much. Thank you very much. So it is very most important comments. So for the Japanese audience have to think about, and also together with world people. Thank you very much.
We are reading this, Ruth. Our students are reading this very important book.
So thank you very much. So now, thank you, Japanese participants again to stay until midnight. But it is extremely stimulating session, and thank you very much to the people coming from the world to discuss these important topics. So we'd like to continue this conversation. So Professor Greco, so could you give us a closing summary and appreciation to all the participants?
You want me to speak, but I want the photograph first.
A photograph, yeah.
Yes, please. If you don't do, I'll do just like Wolf did now. He took his own picture.
Yeah. So please, camera on if you like, if it's possible. So please, your camera.
Can you take a picture from your side there? There's a way of doing that. If not, I'm going to take mine too.
Yeah, you do it. You can do it.
No, I think you can do it through the Zoom. But if not, I'm going to take a picture of myself. It's going to be okay. I'll take it from here. Please smile. All of you smiling. Okay. Thank you. Well, if you allow me 3 minutes, I'm going just to repeat what I have been saying with Kyoko for a long time. It's has been a pleasure to meet them, to meet Kimura, to meet all the group, to meet Kyoko, Takeo, Imamura. I think it has been a very good thing that happened to me since the time I was in Japan about a year and a half, almost a year and a half ago. So putting this together, even if the Brazilian society is part of it, was a work specifically from Kyoko and Takeo. And I praise you, I thank you. I think that's very important. That's a hope that we can keep fighting against inequity, keeping fighting for the people, even if you are not, even if we are not really in the same small boat as everyone is. But I think we have this reason. Keep the indignation together so we can do something more than we have been doing. And I thank you all, and I give the word back to you to say the last goodbye. And as you said, it's almost midnight in Japan. It's amazing. Amazing that all of you are still awake. Thank you very much.
So thank you very much. So we would like to continue this kind of session and hope to see you again, wish to see you again. So thank you very much. So long time discussion. Thank you very much. Goodbye.
Bye.